Um, Hello, my name's Ella Hobbs. I'm an academic foundation programme doctor based in Oxford, and I'm privileged to present our study which shows that oxygenated hypothermic machine perfusion reduces cardiolipin release and improves certain clinical outcomes for higher risk kidney donors. I presented this study as part of the Patey Prize session for the Surgical Research Society in January, and was honoured to win the Williams Prize for the best clinical paper. So the graph on the left is a very well used image, but it very clearly shows the sobering state of kidney transplantation in the UK today. We can see that over the last 4 or 5 years, the number of patients on the deceased donor waiting list has roughly doubled, whilst the number of transplants occurring each year has remained pretty static. In order to combat the rising waiting list, we've increased the use of the extended donor criteria, which includes kidneys donated from patients over the age of 60 or those over the age of 50 with a history of either hypertension, death through intracranial hemorrhage, or a higher baseline creatinine. Now, these kidneys are associated with higher post-operative mortality and morbidity, but they're still considered preferential to remaining on the transplant waiting list. Now, machine perfusion isn't a new idea. It was first thought about by Lindenberg and Carrel in 1938, but more recently, it's been used to try and improve the clinical outcomes of these higher risk donors. These images show how hypothermic machine perfusion work, and we can see how the kidney is bathed in a bath of cold fluid-based perfusate, which is then pumped through a roller pump and can be oxygenated and temperature controlled, and then actively pumped back through a cannulated renal artery. For the purpose of our study, all kidneys were cooled to a temperature of between 1 and 4 degrees, with oxygen delivered at 100% and a pressure of 600 millimeters of mercury. Why look at the mitochondria? Well, we know that in hypoxic environments, the mitochondria produce danger-associated molecular proteins, such as cardiolipin and succinate, and these work by reversing the electron transport chain at mitochondrial 1, and on reperfusion are oxidized to form reactive oxygen species. And these are associated with a number of dangerous and inflammatory processes within the cell and tissue. Cardiolipin, for example, is oxidized to form cytochrome C, which when released from the mitochondria is involved in the intrinsic apoptosis pathway, causing cellular and tissue necrosis and death. So we use samples taken from the phase 3 double-blinded COPE-COMPARE trial with a primary aim of investigating the impact of oxygenation during hypothermic machine perfusion and its impact on end perfusion cardiolipin concentration and clinical outcomes, and a secondary aim of using cardiolipin as a surrogate marker for mitochondrial injury to understand the role of oxygen and the mechanisms behind ischemic reperfusion injury. We used 20 paired kidney donors, with each donor producing 2 kidneys, one of which was randomized to the oxygenated arm and one to the non-oxygenated arm. And we took perfusate samples at 15 minutes into perfusion and at the end of perfusion, measuring cardiolipin concentrations using fluorometric assays. And the table on the screen shows our demographics and clinical variables for each sample. So our most important finding was that cardiolipin concentrations are significantly lower following oxygenated hypothermic machine perfusion compared to HMP without oxygen, with a p-value of 0.038. But this is taking into account that cardiolipin is also significantly associated with perfusion time for both arms of the trial. We also saw that end perfusion cardiolipin is significantly associated with poorer eGFR at 12 months post-transplant, with a p-value of 0.026. But understandably, this association wasn't seen when considering cardiolipin concentrations before perfusion occurred. Cardiolipin was also associated with higher serum creatinine levels at 3 months, although this never reached statistical significance. And the significance became weaker in the ensuing 6 and 12 months post-operatively. Donor characteristics, including sex, donor creatinine, and age, did not significantly impact cardiolipin concentration. And although we did see cardiolipin associate with longer-term clinical outcomes, we didn't see this association when looking at shorter-term and immediate clinical outcomes post-operatively. For example, delayed graft function, which is defined as the need for dialysis in the week post-transplant, and functional DGF, which we defined as not seeing a 10% reduction in creatinine per day for 3 consecutive days in the week post-transplant. So in conclusion, our study showed that oxygenation during hypothermic machine perfusion is associated with significantly lower end perfusion cardiolipin concentrations and therefore reduced mitochondrial injury compared to standard HMP. Post-perfusion cardiolipin concentrations was significantly associated with poorer eGFR at 12 months and higher levels of serocreatinine post-operatively, which therefore suggests that cardiolipin offers a useful surrogate marker to understand the mechanisms behind ischemic reperfusion injury for higher risk DCD kidneys and the role of oxygen in mitigating this, but is potentially a less practical prognostic marker in clinical practice. Thank you very much for listening, and please do get in contact with any comments or questions you may have.